Hello, this is Miss Gibson. All right, let's talk about filtration. This is where you have to use a filter medium. This is the process that separates substances from the blood based on their size. It does not take into account whether they are waste to be excreted or nutrients that are required by the body. The glomerular filtration, that is the final fluid. That's the final that final step in the filtration process. It's adjusted as it flows along the remainder of the nephron. So we know that the glomerular filtration, that's part of the kidneys, which you will learn about if you haven't already. Very important process in keeping us in that homeostasis or that equilibrium. So the next one is diffusion, and this is just a little chart that kind of shows you what it looks like in our body. It's movement from higher concentration to lower, and as you can see, we're breathing in oxygen. It goes down into our lungs and into our alveoli, which are those little grapes that filter in your lungs. And this is kind of what that alveoli looks like. So we breathe in that oxygen, and then we're getting rid of that CO2. Very, very unique little system there of diffusion. Osmosis, so we know with this is a movement of water molecules across a semi-permeable membrane. This is that same process where when you feel thirsty, the hypothalamus gets triggered, and then that's when your body's like, okay, you're thirsty, you need to drink. Hopefully we're drinking water because we know that's really good for us. The body needs water to keep that level state of homeostasis. So some risk factors for fluid deficits or any kind of fluid imbalance is very young and very old. We know that the amount of sub-Q fat is less water reserved when you have more sub-Q fat. So this would be for our obese patients. Need to add, give me just a second, bear with me. I don't know where my mind was there, but I'm going to fix that. Environmental temperature, fluid loss by sweating. We know that this is the insensible loss. This would be running a 5K in 100-degree weather. Our diet, many foods we eat have large amounts of H2O. Your health status, losing body fluids, altered fluid or food intake confusion. A lot of our geriatric population don't get thirsty, so we really have to remind them. Or they may have that urge to take a drink, but then forget. Also, their taste buds don't work like they should, so nothing really tastes good, or it might taste off. And then any alteration in kidney or heart functions. My mind must have been in 100 different places. So this is just going to be a quick overview of our assessment. Of course, we're going to do our I's and O's. We're going to measure catheters, drainage, any drains, like your Penrose drains, post-op stuff. Disease processes. Of course, we know that any kind of kidney or heart dysfunction can cause an altercation in your fluid. Medicines, diuretics, And then the last one is your treatments. And all I mean by the treatment box there is like your wound drainage. It would be difficult to measure that. Some doctors will order for the wound drainage to weigh the like the ABD pad or something like that, but you don't see that a whole lot. Physical assessment. So this is what we're going to do. You're good head to toe, looking at the skin, the mucous membranes, skin turgor, your daily weights, which we know is the most accurate. Any trends in your vital signs, your heart rate will increase for a deficit, for a fluid deficit. Your heart rate will increase to maintain blood pressure with less fluid volume. So that would be your dehydration and your fluid deficit. Your peripheral pulses become weak. A lot of times they're very hard to find. Blood pressure, of course, that will decrease. So your pulse pressures will be off. That's where you want to watch for that orthostatic hypotension, where you don't want them to get up too quickly. We know that the urine characteristics will definitely change. The color will be off. The clarity, it'll probably be cloudy. There'll be a lot of sediment. Your specific gravity, this reflects the kidney's ability to conserve or excrete H2O. It's just telling you how concentrated the urine is. You want your urine to be negative of proteins. Remember that any of your protein molecules, they are too big to pass through the kidneys. So if you have protein or even a lot of blood in your urine, that is definitely a red flag. Should be negative of glucose. However, if your patient has ate a big carb diet or ingested a lot of carbs, there may be a little bit of glucose in the urine. Ketones, we shouldn't see any ketones in the urine. We know that that is a byproduct. And then, of course, your sediment, which could be, red blood cells, infection. Your neck veins, you want them normal. You don't want them flat or distended. You shouldn't be able to see them bounding. Your hematocrit is something that you should be looking at, especially for fluid imbalances. This is the volume of blood that is composed of red blood cells. The red blood cells transport oxygen to our cells. So it's really just measuring the volume of cells in the plasma. Decreased fluid. With your decreased fluid, or your fluid deficit, your hematocrit will be increased. If it is excess, it's going to be decreased. So make sure that you remember that. For your specific gravity, I want to go back to that for a minute. With a fluid deficit, you're going to have an increased specific gravity just because it is more concentrated. And you're not going to have as much urine output. With your fluid excess or fluid volume overload, the specific gravity is going to be decreased. The urine will not be as concentrated because hopefully you're going to have more output. With your I's and O's, we know that it's measured in mLs. You want to make sure that you are also providing that good education to your patient's family or their caregivers that might be there with them. Just kind of encourage them and give them reminders that it's important that they let you know what they drink, that kind of thing. Keep in mind if they have IV fluids going in that you want to make sure you do good documentation with that. I's and O's can be started without an order in most facilities. Just make sure you know your facility's policy on that. You calculate the total usually at the last hour to 2 hours at the end of your shift. The reason you want to do that at the end of the shift is you want to make sure that you are assessing for any trends. Make sure that you remember as well that you want your patient should be urinating at least 30 mLs every hour. Keep in mind your insensible losses. Those are things that can't be measured. Let's see. Some things just to give you an idea with your I's and O's. Make sure that if you do give your patient ice chips that you're taking those into consideration. And as far as the fluids, any foods that become liquid at room temperature, Jell-O, ice cream, popsicles, those should be documented as liquids. Your tube feedings, if you are on, your patient has a tube feeding, if it's on continuous, you want to make sure that you are clearing that at the end of your shift. That way the oncoming nurse will have accurate amounts. If you add water or liquid meds to that, you got to add that to your intake as well. Let's see. Any kind of irrigation fluids used to irrigate, like your Foley cath, your NG tube, you want to make sure you note that. Also, your enemas. With your urine output, you want to use a graduated container or cylinder. You don't want to estimate. The catheter bags, of course, those will have numbers on the outside. If your patient is incontinent, you can always measure your brief or the linens. We don't see that practice a whole lot. Unfortunately, that does get estimated, or a lot of staff just forget to do that. So, and also your tube, your drainage system, you want to make sure that you're taking that into account as well to be accurate. Fluid volume deficits, we've discussed this quite a bit. We want to make sure that we know the causes. If you know the cause of something, then you should be able to pick up on the signs and symptoms. What I mean by that is if they come in and you know that they have, liver disease or cirrhosis, then you would look for that third spacing or that ascites. If they're very athletic, they tell you that they just run 12 miles, you might look for that hyperthermia and know that they probably more than likely are dehydrated because of the sweating. With the extensive burns, the most important thing to remember with that is fluid seeps from the blood into the burned tissues depending on the severity. So the blood vessels, which includes the capillaries, may be affected, leading to increased capillary permeability, which just means that the fluids are moving from the vascular into that tissue. Peds are especially vulnerable to dehydration from burns because they have higher surface area. That third spacing, sorry, I keep moving that. That's just fluid going where it normally does not go. So with that ascites, that is where fluid is moving into the abdominal cavity. We see that a lot with cirrhosis of the liver or liver failure as well. Some of your nursing diagnosis for this would definitely be fluid volume deficit related to whatever your cause is, or you could also do as evidenced by. So some of your signs and symptoms, we talked about these earlier, but you know that their heart is going to be beating faster, so we will have some tachycardia. Their skin turgor will be off. It is crucial that you do good head to toe assessments with this, and you're monitoring for any trends with your lab values, because if it is our vulnerable population, our elderly or our peds, neonates, they will decompensate very quickly. So, as the saying goes, especially with peds, they compensate, and then they just don't. And they hit that downhill slope very quickly. In our peds, their fontanelles or the soft spots, they will become sunken in. With those fontanelles, the purpose of that is to give the skull flexibility so that when they pass through the birthing canal, they're able to pass through that canal with no damage to their brain or their head. It also allows for brain and skull development. You have one that will be found on the top of the head. You've got one on the back as well as the sides. That anterior one, it's located in the middle of the head. It's almost like a diamond shape. It should be closed within the first year. The one on the back of the head, it should close within the first to 2 months. You may actually never feel that one. However, it's very important that if the fontanelles are sunken in, that you get them medical intervention ASAP. So that's very good education to give to parents that have peds, where they can get treatment. So this is just some nursing interventions, fluid replacement, preventing abnormal fluid loss, vomiting, diarrhea. You want to keep their fever in check. You also want to check for pulmonary edema. Make sure that, it just goes along with your good head to toe. When we are rehydrating our patients, we want to make sure that we are keeping an eye on their urine output. You want to make sure that they're still having a pretty equal amount going in that's coming out. You also want to monitor that pulse rate. It probably wouldn't hurt to, if you don't, they probably should be hooked up to telemetry to keep an eye on those important aspects. On table 13.3 in your book, there is a chart that goes over the different IV solutions. I'm so sorry. Make sure you look over that chart as well. So this is just a case study question. Go ahead and read over that, and then kind of pause the lecture and see if you can answer that. There will be vital changes, of course, as we know. You want to expect increased weak, thready pulse. Their blood pressure will be decreased. They could have a temperature just from the hypovolemia. It just depends on how bad it is. You're going to encourage fluids, monitor I's and O's, and of course always monitor those vitals. Now we'll go on into fluid volume excess or hypervolemia. The biggest diagnoses you'll see that goes along with hypervolemia is renal disease or that chronic kidney failure, even with acute renal failure, and heart failure. Those two will be the most popular. So with your fluid volume excess, you'll have a lot of hemodilation, which just means that you got too much fluid in there. Um, let's see. That SIADH, that is syndrome of inappropriate antidiuretic hormone. That's a mouthful. All that means is that your body is making too much antidiuretic hormone, or ADH, which causes fluid retention. When you have fluid retention, you're also going to have hyponatremia, low salt. Some causes of this SIADH is there's certain cancers like your small cell lung cancer, central nervous system deficits, stroke, hemorrhage. Another central nervous deficit could be even trauma. There are some medications that can throw you into this SIADH. Some of your seizure meds, antidepressant, depressants, several cancer drugs, some of your cardiac meds, diabetes. And then you also have surgery, just because of the stress on the body can throw you into that SIADH, as well as hormonal deficits. So here are some more signs and symptoms just for the fluid volume overload. If you look on page 259 in box 13.3, it gives you all of these. Most of your issues with fluid volume overload are related to the excessive fluid in the vascular space, which causes a dilution of the electrolytes and blood components. With the edema, you can first see it, especially with your ambulatory patients, in the ankles. If they're bedridden, this is one area that we just kind of overlook. But if you have a patient that is bedridden, maybe they can't get up, or they're in the unit, you want to look in the sacral area. And that's just from gravity and pulling of all of those fluids. With your lab values, you're going to have a decreased hematocrit, and that's just due to the decreased amount of hemoglobin or decreased binding of oxygen. Your specific gravity of your urine will be very dilute. It'll be a lot of dilution going on there. Your nursing diagnosis, of course, is fluid volume overload related to whatever is causing that. Your good nursing interventions, you're going to assess for the signs and symptoms. They will be on fluid restrictions. You want to assess for dependent venous pulling, pitting edema. You're going to protect that edematous skin from pressure injury. There's not real good blood flow going through there. Of course, the daily weights, which we know are the most accurate way to monitor that. You're going to watch for any trending lab values. You're going to assess for the effect of diuretics. The way that you would do that is with your eyes and nose, making sure that they are able to get rid of or excrete all of those excess fluids. You also want to relieve the symptoms for where that excuse me, I'm so sorry. They may have some shortness of breath, especially if they're having pulmonary edema. One of the most common medications that will be prescribed for this is your loop diuretics, which affect the loop of Henle in your kidneys, and that will be furosemide or Lasix. So you definitely want to make sure that you keep a good vein going, or vein IV site. You may have central lines, that kind of thing. Here's another case study. Go ahead and pause and see if you can answer this. So the one intervention that you could do is put the patient in a semi-Fowler's position to assist with their breathing. You also want to ask questions like, when did your symptoms begin? Have you ever had these symptoms before? Check your breath sounds. You're going to check for crackles in the lungs. Observe for any edema, ascites, distending neck veins. You're going to look at their skin, their temperature, skin turgor, and you're definitely going to monitor the eyes and O's for all of that. So that's it for your fluid imbalances. If you have any questions, if I've confused you, or if I have misspoken, please email me. It's very easy to misspeak, or I know that it's a lot to take in. So please just email me. That way I know, and we'll figure it out together. Have a great day.